Yeah, but it's also interesting just because like she's been bringing up a lot of arguments that I haven't heard other people make on these subjects. So it's kind of actually like it's kind of interesting, um, actually like kind of thinking through some new arguments or new issues. Abby and I were talking a little bit before you got here, just kind of like about some of the general things that have been brought up. So I think it should be like a pretty productive discussion because actually like it's cool. Just because like there's some parallels to to like some problems that you can relate to in like the law, like in terms of we'll discuss like obviously the difference of like weight versus admissibility or relevance, um, like just like how to weigh certain kinds of evidence, right?
Gotcha.
Which is super complicated, but it should be fun.
Yeah, for sure. That sounds really cool.
Myself, so yeah, have fun.
What are all these? What are those noises?
Is that on your end?
Oh, these are people joining. There's a lot of people interested in listening in on this.
Oh, cool.
Well, these are all people joining the conversation.
Very cool. Okay. Oh, ask yourself here. Awesome.
All right. So I'll start the recording. Okay. So, all right. So we'll be going over the debate between Hunter and Lauren Southern. So it's going to be pretty empirical. We're going to start with some basic first principles, and then we'll go into this particular studies that she cited.
Okay.
So the first thing that and if anyone echoes in the background or starts saying things, I'm just going to be server muting them. Okay, cool. All right. So first off, in terms of just quality of evidence, have you heard of what's called the evidence hierarchy before?
Yeah, so that's like at the very top you have metadata and then meta-analysis, and then below that there's like a whole triangle of reliable. Is that like
the locos?
The reliability of different studies, right?
Yeah, that's the basic. So with respect to the same type of study that is trying to answer the same type of question, there's a way of tiering studies that gives stronger or weaker weighting. And so at the bottom of that is going to be just basically editorials, opinions, things that aren't even original research. Almost equivalently weak are going to be things like, at least in the field of biology, things like mechanistic studies. I'm sorry, there's just a little bit of audio backsplash, Hunter.
I'm sorry.
No, it's okay. Yeah, one option is to do push to talk.
Oh gosh.
Or to change the audio input threshold. If you know how to do that.
Let me get this set up for just 3 seconds here, sir.
Yeah, sure.
All right, does that sound okay? I have it on push to talk now.
All right, perfect. Okay, so almost equivalently weak is going to be things like mechanistic studies, Petri dish data, and everything like that. The reason it's weak is because when we're looking at outcomes in biology, there's going to be an enormous amount of mechanisms, and the outcomes are going to subsume the mechanisms. And so when we look at mechanistic data or rodent data and stuff like that, and when we compare it to actual outcomes in randomized controlled trials, it's not that impressive in terms of corroboration. And that makes sense because there's all sorts of mechanisms that are in between a given exposure and a given outcome. Higher than that, so we're looking at outcomes. So there are different types of cohort studies. There's cross-sectional studies, there's cohort studies, and within cohort studies, there's retrospective studies and prospective cohort studies. Higher than that are randomized controlled trials, and then higher than that are meta-analyses of randomized controlled trials. Couple of things to note. Cohort studies there's a reason why prospective cohort studies are more weighty than retrospective cohort studies. So what a prospective cohort study is we start with individuals and we follow them throughout time, and then we assess outcomes. So we look at a given exposure, we see a given population, we follow them longitudinally, and then we assess their outcomes, and we compare them to a control that we did the same thing with. That's different from retrospectively looking at a cohort that we started with the outcome and then tried to look into the past and see any exposures with a given treatment population or a given, same thing for a given control. The reason prospective cohort studies are more weighty is because there are certain biases that they are less prone to, that they're more prone to in retrospective study designs. Recall bias is one of them, and that makes sense. If you're looking into the past, there's going to be things that are going to be recalled differently than if you're just following patients into the future. You have better assessment. There's less possible, and it's also more preventative of reverse causality if you compare prospective cohort studies to retrospective cohort studies. Also, if you compare prospective cohort studies that try to answer the same question to retrospective cohort studies and compare them to randomized controlled trials, the prospective cohort studies, no surprise, end up concording with the randomized controlled trials better than the retrospective cohort studies. So the evidence hierarchy is going to be basically just saying all else equal, assuming we set a given study up as best as we possibly can, all else held equal, a opinion is not going to carry much weight, mechanistic studies are not going to carry much weight, a case report or like or published anecdote, maybe a little tiny bit higher, a case series, a number of published anecdotes, tiny bit higher than that. Case controlled study is going to carry some weight. Retrospective cohort study is going to carry a little bit more weight. A prospective cohort study is going to carry weight, and a randomized controlled trial is going to carry more weight than that. What I'm not saying, and this, a lot of people can confuse this, what I'm not saying is that a prospective cohort study is always better than a retrospective cohort study, which is always better than a cross-sectional study, which is always, et cetera, et cetera. That's not what I'm saying. I'm saying all else held equal, the randomized controlled trial will be more weighty than the prospective cohort study, which will be more weighty than the retrospective cohort study, which will be more weighty than the cross-sectional study. And so what are the things that may be not all equal? You can have things that are not all equal, like follow-up time differences, sample size differences. And you can have, ceteris paribus, exactly. You can have differences in the type of control group that's being looked at. And so just for the weighting part is all else equal, certain studies are going to carry more weight than others. A quick note on meta-analyses. A meta-analysis, the purpose of a meta-analysis is to pool the results of individual studies. So because individual studies can have different results, or because each individual study on its own may not have enough statistical power, the purpose is to see the result of the pooled effect, assuming that each pooled study itself has a reasonably similar amount of design in terms of the question that's being asked. So it's important to know that a meta-analysis is really only as strong as the studies it's composed of. So for example, if you take a meta-analysis of case control studies, yes, that's a meta-analysis, but it's still all else equal going to be superseded by randomized controlled trials, even though a randomized controlled trial is not going to be a meta-analysis. Because even though it has the title meta-analysis, and it is a meta-analysis, it's a meta-analysis of not weighty data. And so that a meta-analysis is, you could think of it as a step more weighty than whatever it's meta-analytically summating. So if it's a meta-analysis of retrospective cohort studies, then it's going to be more weighty than a retrospective cohort study alone. But that doesn't mean it's going to be more weighty than a prospective cohort study or randomized controlled trial. If any, is what I'm saying making sense? If there's any questions at any time, please feel free to interrupt me.
No,
And
really good. I think, yeah, this is really good. Go ahead.
okay.
I wanted to ask really quick, because I'm thinking about talking about this in my follow-up video for everything. What's the difference with that and a systematic review?
Yeah. So the difference in a systematic review is a systematic review does not, the most basic difference, it does not involve a meta-analytic summation. So a meta-analytic summation is a specific statistical test that takes the point estimates and confidence intervals of different studies and summates it into a pooled point estimate and confidence interval. It is, it's actually taking the results of tests, to the results of different studies and performing a statistical test on them and getting an output. That's not the same thing as a systematic review. A systematic review without a meta-analysis doesn't do that. Systematic review, what they're doing is they are in some systematized way, whether they have an inclusion criteria or not, they are taking studies on a given topic of a question that they're trying to answer. And what they're doing is they are gathering the data, they're presenting it, they're giving their best interpretation of the gestalt of the evidence. What they're not doing is they're not performing that in that statistical test. They're not actually executing a meta-analytic summation. The reason it's important, so what are they good for and not? So they're good if you're new on the topic and you want to get an overall gestalt of like where the data stands or whatnot. What it's not going to tell you, what a systematic review is not going to tell you, is if you actually analytically took the point estimates and confidence intervals of this relevant studies, what would be the actual outcome? What would be the point estimate and confidence interval? It's not going to get you that. That it could still be useful if the study data is not good enough to be able to do that. For example, I shouldn't say good, but if it's too heterogeneous to do that, it can also be useful even if the data is applicable for meta-analytic summation, because it gives you access for the work that's already been done to collect all the relevant studies on the topic. So to answer the question, the main difference is one performs a statistical test called the meta-analytic summation, and one does not, unless it's a systematic review with a meta-analysis. Does that make sense?
Yeah, that definitely makes sense. Did you have a chance?
Okay.
I don't know. I don't want to interrupt if you had more for like explaining everything. But looking at the meta-analysis that Hunter sent, do you feel like that was comprised of really like low power data, or what was your perspective on that?
Okay, so that I'll take a look. Send me the specific study. I'll take a look at that one. I mainly have the studies I've mainly dug apart was the ones that Lauren cited, and the cross-sectional study that Hunter cited. But I think I may have an idea of what meta-analysis it is. But if you can actually just post it in the general chat, the link to it,
Yeah,
I
for sure.
can take a look at that. The one other thing I wanted to mention is about sample size. So here's the thing. So the purpose of sample size is to have statistical power. Power, broadly speaking, is your ability to detect a difference when a difference is actually there. So another way of saying it is power is your ability to avoid a type 2 error. So are you familiar with type 1 versus type 2 errors?
Yeah, one's beta, right? I think that's the type 2, and that's the probability of saying that there's like an association without there actually being one.
Yeah, so a type 2 error is failing to reject the null when the null should actually be rejected. And a type 1 error is rejecting the null when it should not have been rejected. So let's say that you can think about it as a type 1 error is like a false positive, and a type 2 error is a false negative. So let's say the null hypothesis, like there's no difference. Let's say the null hypothesis is true, right? So let's say there's really no difference. If you reject the null hypothesis when the null hypothesis is true, that's known as a type 1 error. If you do not reject, the other side of the coin is a type 2 error, which is if there really is a difference. So if the null hypothesis is false and there really is some difference, if you do not reject the null hypothesis, you've made a type 2 error. You've had a false negative. So yes, beta. The probability of that is beta, and the probability of a type 1 error is alpha. So the purpose of your sample size is to have statistical power. And the purpose of that is to avoid the failure of rejecting the null hypothesis when the null hypothesis is false. So if the null hypothesis is false, you want to actually reject it if it is false. The reason I'm bringing this up is one of the little pet peeve criticisms, and I think you do understand this. I saw you have had a few tweets about it. Is that you'll get a study that has a statistically significant result, and then someone will inevitably comment on the sample size. They'll say, "Well, your sample size was only so and so." And if someone says that for a study that rejected the null, they're not really understanding what the purpose of a sample size is. And you might think, well, aren't they saying something reasonable because isn't like a study more accurate when you have more individuals? Well, that's true, but what you have to understand is the statistical test for rejecting the null hypothesis in those z-scores, they've already accounted for the smaller sample size. So when you see a small sample size study that meets statistical significance, it's statistically significant despite having a small sample size, not in virtue of having a small sample size. The increased difficulty of reaching statistical significance is already accounted for in those z-scores. Where a criticism of sample size is meaningful is when the sample size is low and no difference is detected. Then you might say, okay, well, maybe there is a true difference here. Maybe we should have rejected it, or maybe we should have rejected, or maybe we shouldn't have, but we don't know because it wasn't powered greatly enough to detect the difference if the difference was actually there. Okay, yes, I see the meta-analysis you're linking now. Yes, I am familiar with this. I have read this one. We'll talk. So we'll talk about it. But before we do, are you understanding what I'm saying right now?
Yeah, no, for sure I am. So I feel like that kind of was my initial perspective on it, and then I mean, it still is, but a lot of what I was hearing from people saying that like the n value does determine a higher probability of there being a type 2 error, but you're saying that that really only matters if there's like a negligible difference and if it's not very statistically significant.
What I'm saying is the purpose of the n is to decrease your probability of making a type 2 error. That's what it does. Now, if you have the point is, if you've rejected the null, you can't actually make a type 2 error. So let me just post a chart here. Here, I'll post it in general chat. Everyone can see. And Hunter, if you have any questions at all, if you're not following, or if you want to ask anything, feel free to as well. But here is the difference. If you look at general chat, here's this chart between type 1 and type 2 error. Now, what an increase in n in your sample size does is it decreases your probability of making a type 2 error. It decreases because what's going to happen is your ability to detect a difference, if a difference is truly there, is going to increase. So what you're not doing is if you have more and more of a sample size, you're decreasing your probability of making type 2 error. The concern of having a small sample size is you may very well make a type 2 error. You may very well miss a difference that truly is there. Now, if your study rejects the null hypothesis, you'll notice that it's not a concern because it's impossible to make a type 2 error. The reason it's impossible to make a type 2 error is because what a type 2 error is just failure to reject the null that truly that is false, and a false null. However, it's impossible to do that if you reject the null because by definition you've rejected it. So it's not actually studies that reject the null are rejecting the null despite having a small sample size. So that's what I'm saying. What I'm saying is that the main concern of having a small sample size is to make a type 2 error. But if your study is rejecting the null, you're not actually making a type 2 error. You can't make a type 2 error. Is that making sense so far?
Yeah, for sure. So the null in like a lot of the studies that Hunter was citing would be that let me think. So the null in his case, it would be impossible to make his type 2 error because those nulls were already rejected. Therefore,
yes,
type 1 error would be possible, which doesn't really include the n value.
Yeah, so the type 1, yeah, so there's a possibility of making a type 1 error, sure, but that's a different type of concern. So the point here is that the reason is because the z-scores are already accounting for the probability of getting an answer that could have just happened randomly with that sample size in mind. So you get your p-value at the end of the day, right? So the p-value that you're getting, that p-value that you're getting has that sample size already built into it. So the thing here is that this probability of making a type 1 error, the probability of making a type 1 error here is already accounted for in the with the sample size. So if you get your p-value that's less than conventionally set to 0.05. So yes, we're going to talk about multiple outcomes, Uchi. That's a different topic. That's all right. Anyway, the point here is, so let's say you get your p-value to 0.01, for example. What that's telling you is that provided that all the other, like your study is done appropriately and all the assumptions that go into your study go through, then the probability of that happening randomly without the probability that you would see the effect just as great or more is going to be less than 1%. Now that's going to be true even if the sample size is small. The reason that's going to be true even if the sample size is small is because the sample size is already factored into that output. The sample size is already factored into that p-value. Is that making sense?
Yeah, no, that definitely makes sense. My question would be, how do we know exactly this might be a silly question. I probably should know this. How do we know exactly what the null hypothesis is when we're looking at a study?
Yeah, so conventionally the null hypothesis is that there's going to be no difference between the outcomes of whatever intervention you're having versus non-control group. That's typically the null hypothesis is typically that there's going to be no difference.
I gotcha, that makes sense.
And we reject the null when we see a difference with a p-value. Conventionally, it's typically set at 0.05. Now, there's a whole discussion about p-values and what they should be set at, or if we should do away with p-values altogether. But that's a whole different conversation. But conventionally, this is what's done. So when someone says, now this is, just to be clear, this is not to say that if your study hits a p-value of 0.05, it automatically means that your study is correct or something like that. There could be methodological issues with your study. There could be all sorts of things. But what it should tell you is that it's not going to be a concern for. Well, it tells you two things. Number one, it tells you that it's not going to be a type 1, not going to be a type 2 error. And if it is a type 1 error, your probability of calculating what your chance of a type 1 error is not going to be offset. Your assessed probability is not going to be different in virtue of some problem with your sample size. The reason for that is because your sample size has already gone into the calculation of the probability of making a type 1 error. So if someone says, well, maybe you've made a type 1 error because your sample size is too small, the response should be, actually, the probability of making a type 1 error is already outputted. And given that there's no methodological errors of the study, the assumptions that go into the study are true. Given all of that, here is the probability of making a type 1 error, and the sample size has already been calculated into that output. So there's no further information that's being given by someone criticizing the sample size in that case. Does that make sense?
100%, yeah.
Okay, cool. All right, so what we can do is we can go, with all that being said, we can go through the individual studies.
Hey, Avi.
So, yeah, sure.
Before going into the individual studies, there's it might be worth clearing up the relevance of what you mentioned with the hierarchy to debate, right? How that actually becomes relevant in a debate.
Yeah. It becomes relevant in a debate because if all else really is equal and someone brings out a whole bunch of retrospective studies to you or cross-sectional studies to you, you can there's a move you can make in an empirical debate, which is to just dismiss it in virtue of just having a more weighty evidence type. So for example, let's say I have a randomized control trial that says, just for example, let's say I have a randomized control trial that says that omega-3 supplements don't prevent heart disease, right? And someone brings out a whole bunch of cross-sectional studies. They did surveys and they looked at people who took these supplements and people who didn't, and individuals who had heart disease and didn't. They found a very strong association. And they bring cross-sectional study after cross-sectional study to me, or retrospective cohort study after retrospective cohort study to me, or even prospective cohort study to me. I can actually dismiss all of them pretty easily unless there's some strong reason to favor lower weighty evidence over the randomized controlled trial, in virtue of the randomized controlled trial being of weightier evidence type. Now, there could be some reason to have lower tier evidence. So, for example, if the prospective cohort study had a longer follow-up time, if it was 10 years versus the randomized controlled trial would only had 1 year follow-up. But assuming all else equal, ceteris paribus, assuming everything else is equal, assuming there's an equal amount of follow-up time, assuming that the sample size is the same and everything like that, then you can actually dismiss all of those studies, even if there could be a whole bunch of them. But the randomized controlled trial is simply much stronger methodology. And so you can, in virtue of that, your study, even if you have fewer studies, can trump their studies if they rank lower tier on the evidence hierarchy. That's where it comes up in these empirical debates.
You don't mind? I guess you already said this in DM. You don't mind if I facilitate a little bit, just so it's clear,
Yeah, sure.
why some of this info is relevant, and so there's clear takeaways. Because I know with Avi it can turn into a bit of like, okay, that was all true and useful, but I have so much fucking theory in my head now, I'm not totally sure how this applies practically to some of what I'm doing. So I wanted to say kind of like two things. One is like, I'm not sure if it's just that Carissa might have like a bit of a stronger personality or a bit more comfort with the topic, but we also really do want Hunter to get the value out of this also. So we really encourage you, like, don't mind cutting in halfway through if Avi's using words you don't know or if you're not tracking or anything. Just like, please don't hesitate to ask questions. And then the relevance to debate with this, right? Like, so okay, so there's one or two things that should be said. First of all, did you do a study exchange with Lauren beforehand?
I don't think so.
No, I didn't. No.
Oh, okay, I'm sure Avi will speak to this, but that right there is setting yourself up for like a suboptimal situation. It's one thing to go into a debate about philosophy or something, like if you're talking about like gender metaphysics or some shit, without doing an empirical data exchange beforehand, because empirical data is not going to have really much relevance in some kind of conversation about like gender metaphysics or something, right? Like, is it coherent to be a trans person, right? That's the kind of thing where it's not going to be as relevant. If you're doing an empirical debate like this, I mean, I have another point to make after this, but I think Avi will emphasize this too. It's absolutely vital to do a study exchange beforehand. Do you want to talk on that too, Avi?
No, I completely agree. The purpose of doing a study exchange beforehand is that you're going to be familiar with their content. They're going to be familiar with what you're bringing to the table. And you don't have to do any of this, these gotcha studies, basically, I call them, which is you basically are unfamiliar with a study that's being sent to you. And you're in the middle of the debate and you have to kind of like look at it on the fly. And you're not really sure where to go. You're not really sure where it fits into the broader context of the research. You're not really sure what the methodology they did was, and you're just gonna find yourself like a deer in the headlights. Because now you can do the same thing to them. You can like, gotcha study them too, but that's really not going to make for a productive conversation if you're just gotcha studying each other when they haven't actually read the studies. A more rich conversation is going to be had when ahead of time you and whoever you're debating have read each other's studies, have prepared for each other's studies in advance, and then you can debate each other.
Yeah, so that's like extreme. Sorry.
Agreeing.
He just said he's agreeing. The only I want to address, the only reason I might be a little bit more active is because I'm actually like I just took a stats class, so I understand a little bit more, and I'm going to be able to explain it more to Hunter afterwards too. So he's listening and everything, but I might be able to ask a little bit more questions. So he's not that he's not engaged. I do feel like I'm able to understand a little bit, and so if he has any questions, I'm going to be able to explain it to him later. So don't worry about that. But no, that definitely makes sense with the study exchange. I don't think that you knew that they were going to be bringing up studies during the debate.
I didn't think she was going to be picking through methodology, which she didn't even know what she was talking about, too.
Yeah, so, okay, fair enough with what you just said, Carissa, who I will not refer to as Hunter's wife, as per our past discussion. Okay, so, yeah, that's one thing, is do a study exchange beforehand, because the whole idea is, like, if you're confident in your opinion and you think that you're right about this, presumably, like, you believe that, like, honestly, based on your best evaluation of the data, there's no threat to you in exchanging data beforehand, right? And if you do, then you're going to have all their stuff and you can review it with someone who's got expert knowledge if you're not comfortable with any of it. Like someone like Avi, I mean, I'm sure he'll say this for himself too, but he's happy to just sit there when you get a data dump from the person you're going to be debating and just go through it all and see if any of it bears on the debate proposition. So you always want to get a clear proposition. You always want to get the data exchange beforehand. Then with that data and that proposition, you can come to Avi, you have both, and you can just say, does any of this support this? And you'll get a range of like super useful debunk stuff that they're probably going to really have trouble with. So that was one thing worth saying. And then also just, Avi spent a long time talking about the evidence hierarchy. And maybe you guys kind of already got the takeaway of like why that's important for debate, but like in case it wasn't clear, because it wasn't directly stated, it was more like kind of inferred. And then Avi talked about it for a minute there, but the whole idea is like, if you get into one of these empirical discussions, you can always get into like deconstructing the data they gave you, assuming that's the case. But it's important to talk about the like ceteris paribus case, right? Which means all else held constant. So when you both have put data on the table, say you get this situation, okay? You've both put data on the table. You don't see a methodological flaw with their data. So there's no debunking to do, right? But one of you has given data that's higher on the evidence hierarchy. You need to have that tool to appeal to at that point, right? Because otherwise you're just both sitting there going, I have data, no, I have data. And if there's no methodological flaw, there's no other avenue of criticism. At that point, you want to look to the actual evidence hierarchy. So it's going to be valuable in, as you can use it in other cases than the ceteris paribus case, but that's going to be like a vital place where it can be deployed. When both sides are giving data, there's not a problem with the data either side are giving, so there's no room for methodological criticism, but one person is given data that's higher on the hierarchy. Do you guys appreciate what I'm saying there?
Yeah.
No, that makes sense.
Okay, yeah, I know Avi wants to go into the specifics, so I'll kind of butt out.
Yeah. Another thing I'll mention real quick, and then we'll go into the specifics, is the importance of a control group and the importance of having a quote unquote appropriate control group. So the purpose of a control group, if you're trying to make a causal inference for a given intervention, is to know the answer to the following question: what would have happened otherwise? That's the key. Now, so for example, you can just have an intervention on a given group. So I can give omega-3 supplements to people and follow them out over time and see if they're going to have a heart attack, and see how the risk compares to the general population. Or I can just follow them in general, or I can see what their chance of going to the hospital is over time. Now I can see it go up or go down or stay the same. So that answers the question of where you started from and where you're going to. But here's what it doesn't answer. It doesn't answer the question of what would have happened otherwise. What would have happened had I not given that omega-3 supplement or whatever intervention we're talking about? For that, you need a control group. And what is an appropriate control group? An appropriate control group is always going to be tailored to the question you're trying to answer. So in the case of, let's do it in the following case. In the case of transgender individuals who are getting gender-affirming hormone therapy, for example, what you can do is you can follow transgender individuals who have gotten gender-affirming hormone therapy, and you can look at their rate of suicide at year 1, year 2, year 3. Now, you can see it go up, go down, or stay the same. But in all 3 cases, you'll notice a question that's not being answered. The question that's not being answered is, what would have happened otherwise? What would have happened had these individuals not gotten hormone therapy? Does that make sense?
Yes, very much so.
So that's when you
Okay.
get the number of a number similar to that who of like transgender people who are not taking hormones and see what happens to their suicide rates and etc. Right?
Yeah, that's one thing. And another thing to note is that it gets even more complicated than that. So this is where that's the start of a control group, and that's great. It can even get more complicated than that, because remember, so now we're talking about an appropriate control group. Well, what's an appropriate control group? So here's the issue. So it's very hard to get an appropriate control group in these studies because some transgender individuals are actually happy with where they are in their transition. They're happy with they are without further modification. So, for example, if you're looking at gender-affirming surgery, you have a number of transgender individuals who are not dysphoric and completely happy with hormonal transition without any surgical intervention. Now, you might look at transgender individuals who did get surgery and look at their suicide rates compared to transgender individuals who did not get gender-affirming surgery. And you may see no difference. But the key to remember there is if all you did is look at a control group that has individuals who had gender-affirming or that did not have gender-affirming surgery, what you're actually doing is you're including transgender individuals who didn't actually want the gender-affirming surgery. Just because they didn't get it doesn't mean they didn't want it. Just doesn't mean they wanted it. You can have transgender individuals in that group that are completely happy, non-dysphoric, and they're completely attuned now with where their mental state is and where their body is. And to include that as a control group is not going to be appropriate with respect to the inference you're trying to draw, with respect to the question you're trying to answer. Because what you're not trying to answer is what would have happened if you didn't get the therapy and you didn't want it. The question you're trying to answer is what would have happened if you didn't get the therapy and you did want it and you weren't happy with your body and you couldn't get the therapy or didn't get the therapy. That's the question that's trying to be answered. Does that make sense?
Yeah, that makes sense.
Okay, cool. So you'll find that a lot of these motifs come up in the studies that Lauren has cited. So we'll go to some of the major ones. The one that she has touted as that nail in the coffin for how gender-affirming hormonal therapy doesn't work is the Bradstrom and Pachanka's study. So I will post that study in the study archives in general chat, and we can go through it together. So it's an interesting story because this publication was published I believe in 2019, and it's gotten a whole lot of criticism from statisticians, and then they published a few corrections, and then they did additional analyses, and the whole thing is it was kind of a bit of a mess, but we'll go through it, and we'll go through what Lauren claimed the study said it showed and what it actually shows. So can everyone see? I linked it as a PDF in general chat. Can everyone access that?
Yeah, we got.
All right, cool. So I'll post the abstract because that's, I think, all Lauren has actually read of this study. Actually, I could be wrong about that, but it seems that way. Here is the abstract. And what seems to be what she's talking about is, you see where it says in the results, years since initiating hormone treatment was not significantly related to likelihood of mental health treatment, adjusted odds ratio, 1.01 with a confidence interval that's crossing the null and is not significant.
Yeah.
Yeah, so that's one thing that they talk about. And so what they're looking at is they're looking to see if there's an association between time since hormonal therapy and probability of certain outcomes. So time since hormonal therapy and probability and relative, the odds ratio of either odds ratio of, so association of time between gender-affirming hormone and surgical treatments and hospitalization after a suicide attempt or treatment, and it wasn't significant. I'll post that part of the paper over here. All right, let me post that in general. Okay, so you see where also it says in the association between time since gender-affirming hormone and surgical treatments and hospitalization after a suicide attempt did not reach significance. For hormone treatment, the adjusted odds ratio is 1.12 with a confidence interval that crosses the null. surgical treatment odds ratio 0.87 with the confidence interval that crosses the null. You see where it says that?
Yeah.
Okay. And so she looks at that and then she says, okay, look, hey, like this therapy isn't actually helping. See, like their risk of suicide is not decreasing. Now, based on what I've told you thus far, what's the issue here with this type of inference?
So first off, they they exactly what you said is an issue, is that they're not measuring the people who wanted surgery but didn't get it. And secondly, too, they're only, well, I think they also measured like the medication too, not just like the surgery. And you can't necessarily say that just as long as they're taking like the same medication from one point in time to another point in time, that their mental health hasn't necessarily improved. So both of those are kind of issues.
Yeah, so I hear that. There's something a little more. So yeah, so those absolutely are, and we'll see the further attempts they did, and your criticisms would absolutely apply to that. A very striking thing here is that what's the control group here? Is there any control group at all in terms of in terms of this specific analysis? In terms of the analysis of looking if there's an association between time for individuals who have received hormone treatment, a test to see if there's an association for time that you've received treatment and your chance of committing suicide or attempting to commit suicide. What type of question is that answering? Is that answering the question of where you were compared to where you are, or is that answering the question of what would have been otherwise?
It's the first one. It's not what would have
been. Exactly. So you can have you can even have an increasing risk of you can have a risk of suicide that isn't changing since your hormone therapy, but that's not answering the question of what would have happened otherwise, which is important because it could very well be the case that if you had not undergone hormonal therapy, your risk of suicide would have increased instead of staying the same, or increased even more if it even increased. So that's why it's important to understand both of those questions. We need an answer to the question of where you are compared to where you were. And we also need the answer to the question of where you are compared to where you would have been otherwise. That's the key. And this type of analysis doesn't actually answer the where you would have been otherwise question. All this does is follow people out and shows that the rate of suicide wasn't actually changing over the years. It's not showing that there isn't a difference in suicidality that would have happened otherwise. So it's important to understand what this test is addressing, what type of question is it answering, and what type of question is it not answering. Does that make sense? Is any questions at this point?
No, we're good.
Okay, cool. Now the next, so what I'll tell you about what happened after is that these, so there was a whole bunch of statistical backlash. There were a bunch of statisticians have heavily criticized the study, and what they attempted to do was they attempted to do just that. They attempted to get a control group. And I'm going to post the PDF of what they did there. So now I'm posting a PDF. This was a publication after the criticism. So here it's in general chat. You can all download it. And I'll post the screenshot of the relevant table. All right, does everyone have access to that?
Yeah, we're good.
So what they did after, because of this criticism, was they actually tried to do the thing they didn't do. Now you'll notice, first of all, this is not for hormonal therapy. This is just for gender-affirming surgery. So what they did was they took individuals diagnosed with gender incongruence who have received gender-affirming surgery. and that was 1,018 patients. And they compared it with individuals diagnosed with gender incongruence who have not received gender-affirming surgery. And they matched it with an equal sample size, and they were matched for age, gender, education, and country of birth. Now, what does this tell you and what doesn't it tell you? Well, the results actually were they were still the same. So even though, we had our first criticism where, well, this doesn't actually show you what would have happened otherwise. So they tried to address that. They tried to get a control group. Okay, well, what would have happened otherwise? And it still didn't show any difference. But what's the issue here? Well, first off, this actually isn't hormonal therapy. It's just comparing people who didn't receive gender-affirming surgery with those who did. In both cases, though, they're commonly on hormonal therapy either way. So it's not an inference with respect to hormonal therapy. It's an inference with respect to gender-affirming surgery. But here's the important point. What's the important problem here?
The issue is that we don't know if the people who didn't receive gender-affirming surgery actually wanted it in the first place.
Exactly. So very commonly, trans people are happy with hormonal therapy and they don't want surgery. Now, if you have those people you're comparing it to, you wouldn't expect there to be a difference in suicide rate. You wouldn't expect taking someone who is completely happy, non-dysphoric, and attuned with their mind and their body without surgery, and then you wouldn't expect their suicide rate to go down by giving them surgery. They're already okay. They're already happy. That's not the type of comparison you're looking for. The type of comparison you're looking for is a comparison for individuals who have received surgery compared with individuals who desire surgery. They want surgery, but they haven't had it yet or can't have it. That's the type. And then compare their suicide rates. That's the type of comparison you want to have. Does that make sense? Any questions?
No, that makes sense.
Yeah, that makes sense.
Okay. Now, has there been a study that actually did that comparison? So there are a few studies that have done that comparison. Here's one. And so here's the PDF. Okay. So can everyone have access? Everyone have access to this PDF?
Yeah, we have.
Okay, cool. I'll post the relevant table, which is table 3. I'll post the screenshot. Okay. All right. Does everyone see table 3 in the chat?
Yes.
Okay, cool. So this was a study on 433 trans individuals, and they split them up into they split them up by certain questions. For medical transition status, they split them up into the following 4 categories. Category 1 was, have they medically transitioned already? Category 2 was, they're in the process of medically transitioning. Category 3 was, they are planning medically transitioning, but they have not begun medically transitioning. And the 4th category was that they haven't been planning, or they weren't sure, or they didn't really have a strong desire to plan, to have to transition. And what you see in there, if you look at proportion attempting suicide in the past year, you see that the lowest category or proportion of committing suicide was 1%, and those are those who have already medically transitioned, followed by those who weren't even planning on transitioning. They didn't have the desire to transition. That was 3%, and they give you the confidence intervals. The 1% was 0 to 3, and the 3% was 0 to 7%. proportion attempting suicide in the past year is striking were those who were planning but have not begun transition, or those who are in process but have not completed transition. That is to say, the individuals who were not happy with their body, they want to change their body, but their body has not changed yet. Those are the individuals that had the highest suicide rate. Can everyone see that?
Yeah.
Okay, cool. All right, so there are other studies showing this as well. Some other studies I will give is a prospective cohort study, which is, let me see if I could find this over here. It is a Word document. Let me see. What it is a prospective cohort study of individuals who wanted, this is a Word document. It's a prospective cohort study of individuals who wanted to transition but were denied transition or had delayed transition. And I'll post the relevant table over here. So and this isn't as hardcore of an outcome as attempted suicide, but what they did measure was they measured instruments for gender dysphoria, and they measured instruments for depression. And what they found was that individuals who wanted transition therapy and received transition therapy had lower depression and had lower gender dysphoria than those who wanted transition therapy and did not receive it. So I want you to add that study to your list as well. And importantly, that's a prospective cohort study. So again, in terms of keeping in mind in the evidence hierarchy, that tiers higher, all else equal, than retrospective studies or cross-sectional studies. Now, there are a few other studies that do this as well, but not with suicide, with other metrics. A couple of other studies have this. There's a systematic review that I'll post that goes through various different studies that I think is important. Let me see if I find this here. Let's see. And I think your meta-analysis has gone through some of that as well. Okay, here it is. Yep, that's the 2010 meta-analysis. But there was a very recent systematic review that had this those following studies. Let me bring that up. Okay, here it is. It's hormone therapy, mental health, and quality of life among transgender people. A systematic review. Let me post that. I'm posting that in general chat over here. And you'll find it's very shocking in this study. You'll find that this is the most up-to-date systematic review that I'm aware of. And very few studies have controls at all, let alone appropriate, quote unquote, appropriate controls. That being said, the ones that do show a clear picture. They show consistently that compared to those who did not receive any form of transition therapy and wanted them, if the ones who did receive transition therapy had lower rates of various instruments assessing depression. So what we do have a lot of data on and what we don't have a lot of data on is the following. We do have a lot of data on answering the question of where you are compared to where you were. And most of that data shows that after transitioning with either hormonal or surgical gender-affirming processes, things get better compared to where they were. That's where the majority of the data, if you look at the meta-analyses, that's when you pull all the broad observational data, that's where the leaning is. There are very few studies that answer the question of where you would have been otherwise. Of the studies that answer the question of where you would have been otherwise, they consistently show that you are in a better position than where you would have been otherwise. Either you have a less risk of suicide compared to the control, or that you have a lower score on depression instruments compared to the control, or you have less gender dysphoria compared to the control. And the only cases that don't show that have obvious problems in what the control group is, namely comparing it to individuals who could very well not even want that additional surgery in the first place. But when you do actually parse that out and compare it to individuals who are not currently happy with their body, who do want surgery, you do see the benefit come back. You do see the effect again. Any questions so far?
No, that's really interesting. The last study that you put in, you said that it actually had a good control for where they would have been otherwise, correct?
Which last one are you talking about?
The one that you just put in general chat, the BVAB0112.
Oh, that's actually that's a systematic review. That was a systematic review of multiple different studies, and only like 2 or 3 of them actually had control groups at all. Just to give you an idea of the scarcity of control groups at all, let alone appropriate control groups.
That makes sense.
But the ones that, but the ones that I am aware of, the ones that have control groups that are appropriately done that I am aware of do clearly show that striking difference. Remember the one I showed earlier with the 1%. 1%. That's what it goes down to after they've transitioned medically, compared to 18 or 27%. Now you'll notice it's important because, interestingly enough, those who aren't planning on transitioning, trans individuals who are not actually planning on transitioning in the first place, they have a fairly low rate of suicide. It was only 3%, confidence interval 0 to 7. Want to change their body, or that they have dysphoria, or that they have certain plans of changing their body, what's the best thing for them in terms of their suicide? What is going to happen if they change their body compared to if they do not change their body? And if that's the type of question we're trying to answer, we need to tailor our control group around that appropriately. And when we do that, we see there's a clear benefit. Does that make sense?
Yeah, for sure.
Okay, cool. So to answer the question about the meta-analysis that Hunter brought, so that meta-analysis does a very good job at answering the question of where you are compared to where you were. Does a very good job of that. There's robust data there. There's a lot of observational data. There's even one, I'm not sure if it's in that meta-analysis, but in a systematic review, there's actually one randomized controlled trial. So it does a good job at answering that question. There's little data on the question of where you would have been otherwise, but of the best available data we have, the best available studies we have that have those appropriate controls consistently show that you are in a better position compared to where you would have been otherwise. That's the key. So regarding Bragstrong and Pajankas, Lauren, I mean, I don't think she did it in bad faith. I just don't think she understands research methodology. I don't think she understands how to read the study she's reading. What she inferred from that study is not what you can infer from that type of test. It's not even close to inferring what she said as a result of that. Despite her going on reviews on other streamers' channels and mentioning it like 5 times as the nail in the coffin study. That's just a misunderstanding, a misreading of the study, and a misunderstanding of what you can infer from those tests and what they're actually comparing and not comparing. The other thing that she mentioned, so before we go on to the IQ stuff, are there any questions about that part of the debate?
No, that definitely makes sense. I think we're clear there.
Okay. The other thing that she that Lauren mentioned was concerns about IQ. Right. That was the in terms of puberty blocking medication. So there were 2 studies, I believe, that she cited. There was the I don't know how to pronounce the name, but I don't think she did either. The 2016 one and Mall 2001. Am I correct on that, or are there any other studies that she brought to the table? I'm pretty sure those are the only 2.
Yeah, that one, the IQ one, and the one that we already went through are the main ones.
Okay. So so we'll do it one at a time. So the 2016 one, that study, they let's see. So a couple of things there. So the findings weren't statistically significant, but you could still make an argument that there was an 8-point IQ gap, and it was close to statistical significance. Although there's a whole bunch of contention with that. It's important to look at the methodology most of all. So what type of study were they doing, and most importantly, what were the controls? What type of controls were they looking at, and what type of interventions were they looking at? And in that study, they had 15 treated girls and 15 controls, and they had a condition. Okay, the condition was central precocious puberty. That's a disorder of the hypothalamic pituitary axis in which individuals undergo puberty at an abnormally early age. All right. So that was their treatment group, and they were given puberty blockers to delay it. Their control group, here's what the control group was. Ready? The control group was the general population. And what they found was that the treatment group that had got puberty blockers for central precocious puberty had a difference in IQ, not statistically significant, close to statistical significance, but not statistically significant. Still, though, they want to say that's concerning. They had a drop in IQ that was maintained, I believe, after 2 years as well. Now, the inference there is that the puberty blocker decreases IQ. What's the issue? What's like the most striking issue with this?
The most striking issue is that they're not comparing it to an adequate control group, because comparing it to a general population and not to the population.
Good. What would an adequate control group be?
Let's
think about that.
Would be for people with the same condition not actually being treated with the puberty blockers and tracking those people's IQ.
Good. Yes. Good. This is a breath of fresh air. Excellent. That's the key here. So if you're going to try to make an inference, if the medication you're looking at is if the medication that you're looking at is actually the causal agent here, what you want to do is you want to compare individuals with CPP who have taken the medication compared to individuals with CPP who have not taken the medication. What you do not want to do is compare individuals with CPP who have taken the medication compared to individuals in the general population. Because now there's 2 major things that both can result in a drop of IQ. There's the medication, and then there's the condition in general. And this is, now, I don't think it's actually been done where they have an appropriate control group, so I think it's still an open question. But what I can tell you is, in my previous experience, when I've looked into various medications that have this type of study design, when it's corrected, the difference actually goes away. One example I'll give you is SSRIs, the antidepressants, in pregnant women and childhood and children outcomes, neonatal outcomes. So they used to think that SSRIs were linked to things like developmental abnormalities in children. Some have linked it to autism. Some have linked it to Budd-Chiari malformations. And the inference there was that they took depressed women who were pregnant, who received SSRIs, and compared that to pregnant women in the general population. What's the obvious problem here?
They're not controlling for the actual like depression, so they would have to, a better control group would be comparing them to depressed women who weren't taking SSRIs.
Exactly. And when they did that, guess what happened? There was no difference in rates of any of the abnormalities. So it actually turned out to be that women who were depressed just had a higher rate of having children with certain abnormalities. It had actually nothing to do with the medication. And that's the same problem here. The most striking problem here is you have a completely irrelevant control group that you're trying to compare to. If you're trying to answer the question of, is this medication actually causative to this outcome? Does that make sense?
Definitely.
Okay. The other study actually just had no control group at all. There's not much else to say.
Which study are you talking? The
Mull 2001.
Gotcha.
Yeah, was this the
What's that, Hunter?
was this IQ one, just to be clear, the one you're talking about, I think, was this one with the adopted girls and precocious puberty being treated, and they found the drop in IQ?
Well, there are two ones with precocious puberty. One was with 15 treated girls and 15 controls. And then the other one was with 25 treated patients and no controls.
Okay.
So the one that with 1515 was Wajens's 2016. I'm probably pronouncing that incorrectly. And then the other one was Mult 2001. That was the no control group 25 treated participants.
That makes sense.
So this was.
We're just going over it because I think
I have it already in the script. I want to make sure it's the right study.
We were thinking there was only one. I think the newer one referenced the older one. Is that correct? The newer study?
I believe I wouldn't be surprised if that's the case. I'm looking at an editorial that references both of those studies. I'm sure one references the other. Or at least I wouldn't be surprised if that's the case. But regardless, those are the issues with those two different studies. No, it wasn't a crossover study. The subjects didn't serve as their own control. I don't even know how you would do that with going versus like not. You'd have to reverse puberty for that to happen. That would be really something. Like designing a crossover study would be very complicated for that type of problem. Yeah, it would have to be a parallel design, I imagine. But the point is that neither of these studies had an adequate control group. One didn't have a control group at all, and one had a comparison group that was just simply the general population.
That makes
all right. Any questions about anything we've gone over so far?
No, so far everything sounds good. I'm just trying to figure out which study specifically Lauren referenced.
I heard her talking about the 2016. The reason I remember this is because she said she couldn't pronounce it. So the Wajnu's 2016, that one had 15 and 15. and they had a 7-point drop in IQ. Is that the figure she mentioned?
Yeah.
Yeah, that's the one.
Oh no, or the okay.
It was
Or
the
actually, the
second
Wagens had like an 8-point drop, but then she mentioned the mole one. Whether regardless, either one. I think because I remember she may have mentioned one and looked into the other. I forget the actual particulars, but I know she mentioned the name of Wagens. I remember that vaguely. But the issue with that is just really simply they compared it to the general population, and the issue with mole was that they didn't have any control group at all.
That totally
And
makes
so
sense.
the point is that I mean, here's the thing: like a IQ drop of 7-8 points with an individual that has a manifesting disorder coming from the brain is really not surprising. The disorder is central precocious puberty. That's a brain issue. That's a problem with the hypothalamic pituitary axis. And so it's not really crazy to imagine that an IQ can drop when that condition manifests.
That makes sense.
And so you really need to compare that to that condition without the medication to that condition with the medication.
And I know you're wanting to match up the study with the exact, there's the criticism with the exact study she mentioned, but like, I mean, we'd have to look at the video and find timestamps and stuff to do that, which probably isn't the best use of time right now. But like, as long as you're aware that there's 2 of them and there's a separate debunk for each one, there's no control group, one, the control group is inappropriate. When you're looking through the video, you can just, make sure you have the right one and line it up with the debunk, as long as you're clear on what they both are and which study they match with.
I think I looked it up because I listened to Destiny's take on this, and I think I looked it up then, and I think it is the same one that Avi is talking about, so I don't even think it's an issue.
Oh yeah. Well, you should be aware of both either way, because someone can actually, even if it was the no control group one, then someone can always bring up the one with the control group. So just be aware that having an inappropriate control group can invalidate an inference just as a maybe not as embarrassingly as having no control group, but it can definitely be an issue. And often in this type of inference, quite often is an issue, because when you actually do have an appropriate control group for these types of issues, you do see actually this difference go away. Now, does that mean it'll go away in this case? I don't know. To my knowledge, that study has not been done, and it's an open question.
I think that Avi and I would also both really caution you against like taking what Destiny says at face value with respect to like statistics, philosophy, logic, research methodology.
No, that's fair. I guess my only reason was I was just curious what you would say, and I also just looked stuff up. But yeah, I understand he's not like an expert on any of those things.
No, like he'll do stuff. We won't cascade off into this, but he'll do stuff like bring on, quote, like people are supposed to be experts in stats who like equivocate between statistically significant mean difference and confidence interval non-overlap, just like level 0 stuff like that. Avi's tried to point out errors to him. He doesn't really take correction. It's a cringe show.
That's totally fair.
Anyway, so that all.
Well, I mean,
all
do you
being said,
disagree?
No, I don't disagree. I don't. It's unfortunate. Without cascading up, I think there are some people who really have a lot of potential, and it's just a shame to see them not reach their potential out of just not learning things like formal logic, statistics, research methodology. But yeah, all right, whatever. In any case, so that's basically the gestalt. There's maybe a few more other studies that I can send over, and some meta-analyses, but I think that's the major portion of the talk. So is there if you have any questions at this point, I'm happy to answer anything in particular you want me to look at, or anything particular you want to ask me, I'm happy to go over.
I guess the only question I feel like that we had was more the meta-analysis that Hunter cited, if that actually was as strong as we thought it was.
The systematic review, you mean?
So it depends on what question you're asking. So if you're asking the question, if you're asking the question when trans individuals receive transition therapy, whether hormonal or surgical, if trans individuals receive therapy, where are they likely to go? What's their suicide rate likely? What's their depression symptoms likely to turn into in terms of like where they're going to score on the various instruments? The meta-analysis is robust and strong to answer that question. What the meta-analysis is not as robust or strong is to answer the following question: what would have happened otherwise? Right? And the reason it's not strong to answer the question of what would have happened otherwise is very few of those studies actually had control groups. Now, someone might say that, well, how do you know it actually helps? Well, the answer to that is if you actually look at all the best available evidence that does have control groups appropriately done, they actually do consistently show the same thing, which is that you are better than you would have been otherwise. So to answer that question, I wouldn't actually use a meta-analysis. To answer that question, I would use the individual studies that have appropriately done control groups. And the reason I would do that is because there aren't actually enough studies that have appropriately done control groups that you would have a robust meta-analysis of, because there's so few. Yet, in spite of that, those few studies that have appropriately done control groups do clearly show that you have favorable outcomes with gender-affirming therapies. So if the question is, yeah, go ahead, Isaac.
Well, yeah, I was going to say two things. Like, if you cited it in favor of the wrong thing, I mean, no shame in that. It's just an opportunity to self-correct and then, get points for being an intellectually honest person and putting out good quality info to your audience. But we can also clear this up probably. Like, what point did you cite the study in service of, or points if there's more than one of them?
It was that it bettered their health. So in hindsight, it probably would have been better to use a different study, but that was the best one I had on file at the time.
Well, even saying better health, that's still ambiguous. You could mean it two things, right? So you could mean it in the sense of they end up having better health than they had before. That's one sense you can mean better health. And the other sense you can mean it in this context would be better health than that they would have had they not taken the intervention. Do you appreciate the difference?
Yeah, I can see the difference. I mean, the argument we were arguing about was that gender transition bettered their health. So it kind of worked, kind of didn't. I think that generally speaking, though, either way, my kid is up, so I got to split. But thank you so much for this advice. This has been really helpful. And although I wasn't that active in the conversation, I was listening to the entire thing.
Yeah, for sure. It's my pleasure. Yeah. Anytime you want to reach out.
Final quick point.
Appreciate it.
If you can,
I really appreciate it. And I'm doing a video response about the debate and everything else. So I'm going to use some of the literature you sent me. So I really appreciate it. Thank you.
A final quick thing, if you can spare a second or two, just with the point you're asking about, because you want to know if what you said made sense or not. There's this idea of like quantification in logic. So it's like what domain of things you're speaking over. Like the point Avi's trying to convey is just that if you say better health, that's quantifying over this big range of situations, like better health in this sense or in this sense or in that sense. So it's just saying there's a sense in which the claim is true. There's another in which it's not true. So it's just depending which one you want to talk about. And
yeah. Okay, thank you.
Last thing, just because this is kind of important takeaway. Sorry, I know you got to get to your kid, but just going forward in the future, don't hesitate to hit up Avi. I mean, maybe he should say this too, so it's obvious it's not just me saying it, but like he'll be happy to help you out with this kind of stuff. You have future debates coming up to do prep beforehand if you can get their data off them, or even if you need help doing any kind of like analysis for videos or whatever. I'm sure you agree with that, Avi.
Yeah, absolutely.
All right, that would be great. Thank you.
Peace out, guys. Thanks for setting this up, Carissa.
Oh, thank you for offering. If it's cool with you, I might go ahead and we might finish the script for the video, and I might just send over some of the more stat heavy stuff, dealing a lot of what you were talking about today. And maybe if you wouldn't mind just looking it over, and we can even say that like we had as an actual like authority figure look over it, if that's okay with you.
Yeah, absolutely. Listen, we have it's not just me. We have actual statisticians in the server as well, and they're usually happy to also lend their eyes to various data. So yeah, no, I certainly would be happy to take a look at it. And there are statisticians in the server in addition that may be happy to do it as well. So yeah.